Today we're going to talk about techniques of resuscitation and stabilization of a neonate, Chapter 4. I want to begin by reviewing fetal blood flow. As you see here in this diagram, with fetal blood flow, you start with blood coming from mom through the placenta. The placenta will carry deoxygenated blood through the umbilical vein. The umbilical vein will then shunt blood to the liver and the inferior vena cava through the ductus venosus. The ductus venosus will then dump blood into the inferior vena cava, which will send blood to the right atrium. Most of the blood that enters the right atrium will then cross over into the left side of the heart to the left atrium through another shunt called the foramen ovale. Now, some of the blood that comes into the right atrium will go down into the right ventricle and then go out to the pulmonary artery to get to the lungs and then back through the pulmonary vein. But once it gets into pulmonary circulation, because the pulmonary vessels are constricted, the blood that enters pulmonary circulation will shunt through another shunt called the ductus arteriosus. So you get blood that did not go to the lungs, but was sent back into circulation so that it can go out to the rest of the body. Okay, so the blood that enters the right atrium crosses over to the left atrium, then goes down to the left ventricle and out through the aorta. So the pressures on the right have to be higher than the pressures on the left so that blood will flow through this shunt, the hole that's in the middle, it's a hole with a flap that's in the middle of the heart. The blood will flow from the right to the left so that that oxygenated blood can get out to the rest of the body. You also have constricted vessels in the pulmonary system. So the pulmonary circulation pressures will be higher than the pressures in the systemic system because you don't need as much pressure in the systemic system because the vessels are all dilated. Versus in the pulmonary circulation, the vessels are constricted, so it's under a higher pressure system. Unlike in the adult circulation, excuse me, or once the baby comes out and is in our atmosphere, the left side of the heart is under more pressure than the right. So it's opposite of what's going on when they're in the womb. As a fetus, the right side of the heart has a higher pressure than the left side of the heart. Once they come out of the womb, the left side of the heart has a higher pressure than the right side of the heart. Also, when they're in the womb, systemic system pressures are low, pulmonary system pressures are high. However, once you are born, those pressures swap. The pulmonary pressures are lower and the systemic pressures are higher. Okay, so that was a quick review. This just shows a picture of the placenta and all the vasculature that is supplying the placenta with blood coming from mom. Then the structure will send blood through the umbilical vessels, through the umbilical vein going to baby, umbilical arteries coming from baby going back to the placenta. And once we deliver the baby, obviously the baby is going to be severed from the umbilical cord so that we can assess the baby. So the placenta is typically still inside of mom. They will cut the umbilical cord and then mom will deliver the placenta sometime thereafter. So while we are working with baby, we have this umbilical stump area here. Once it's cut, we will deal with the umbilical stump in order for us to assess what's going on with circulation. So before you can really assess what's going on with the baby during a delivery, you have to consider some things that might have happened in utero. So where ventilation is concerned, our major thing that we need to know is if the baby is apneic, how long have they been apneic? And there's a way that we can determine that by figuring out whether they are in primary apnea or secondary apnea. With primary apnea, it is when the baby has been asphyxiated, and usually that happens because the baby is hypoxic or experiencing hypercarbia and or acidosis. The most common causes of asphyxiation are maternal hypoxia, insufficient placenta blood flow, blockage of umbilical blood flow, and fetal disorders. So when any of those factors occurs, the fetus will first become hypoxic. Once hypoxia has set in, the baby will begin to ventilate rapidly in an attempt to reverse this hypoxia. However, if the hypoxia is not corrected, the baby will stop breathing. Ventilations will cease. And at this point, we call that primary apnea. When primary apnea occurs, the heart rate and the blood pressure will both drop. So we call this decelerations. We will have determined that the baby's heart rate is starting to decelerate. As long as decelerations are in conjunction with contractions, we expect those. But if outside of contractions, the heart rate is starting to drop on the fetus, then that is a big concern. Reason being is after primary apnea kicks in, the baby could end up with secondary apnea. So if hypoxia continues, the fetus will make a second attempt to ventilate. The ventilations are weak, gasping, and ineffective. When these ventilations cease, we call this secondary apnea. So the baby goes apneic initially. They'll make one last ditch effort to try to ventilate. And if these ventilations are not effective in getting the oxygen levels up, then the baby will cease to make any further attempts at ventilating. Again, we call this secondary apnea. During secondary apnea, the fetus will not attempt to breathe again unless resuscitation is started. So we would have to manually ventilate the patient in order for their body to respond on its own. Untreated secondary apnea will cause the heart rate and blood pressure to drop until death. So if a baby goes into secondary apnea in utero and we do not respond emergently, once the heart stops, then that's it for the baby. So when a baby is born, we have to determine when they are apneic, is this primary apnea or secondary apnea? What are we dealing with here? The way that you know the difference is if you try to stimulate the baby and they don't respond. Stimulation should cause those processes to kick back in again. And if it does not, then you're dealing with secondary apnea. So baby is born, they hand you the baby is apneic. You are going to dry that neonate, stimulate them as you're drying them off. If they start back breathing, then you know that that was primary apnea. If they do not, obviously you're going to ventilate for them, and at some point the fetus may start, I'm sorry, the neonate may start breathing again, and that is an indication that they were in secondary apnea because you were not able to get them to breathe on their own by tactile stimulation. Okay, so a neonate that is born asphyxiated will have pulmonary vasoconstriction. We talked about that earlier when we did the review of the blood flow through fetal circulation. But if they are born asphyxiated, the vessels in the pulmonary system should dilate normally, but in this instance, they will stay vasoconstricted. And we call this persistent pulmonary hypertension, PPHN. And the N stands for of the neonate, persistent pulmonary hypertension of the neonate. So blood flow is diverted through the foramen ovale and the ductus arteriosus. So those shunts will remain open if you have persistent pulmonary hypertension of the newborn. The foramen ovale and the ductus arteriosus should remain intact. And if the pulmonary vessels are constricted, those shunts being open and patent will allow for blood to be diverted or be able to bypass the lungs, causing ventilated alveoli not to receive the necessary blood flow, but it does allow for blood to mix. So you'll have a VQ mismatch. And this VQ mismatch, due to blood flowing through the shunts and not going to the lungs, is called persistent fetal circulation. So if the shunts that are only present during the time that the fetus is in utero, if those shunts are still intact, we call, once the baby is born, we call that persistent fetal circulation. So in severe cases, sodium bicarb is given to raise the pH and create enough vasodilation to increase blood flow into the lungs. So that's the desired result. We want to, in persistent pulmonary hypertension of the newborn, the goal is to vasodilate. We want to get the pulmonary vasculature to dilate so that the hypertension that the baby is experiencing in the pulmonary system can now be resolved. Once we resolve that, we then need to cause these shunts to close, the foramen ovale and the ductus arteriosus, or patent ductus arteriosus at this point. We need to get those shunts to close in order to reverse the persistent fetal circulation. So this is an example, a visual of what is happening in persistent fetal circulation. So on the left, this is what should happen once the baby is born. All of the shunts should close, and you should have blood flowing into the right atrium and right ventricle from the systemic circulation. This has deoxygenated blood. It's going to send that blood to the lungs by way of the pulmonary artery. Once it gets to the lungs, it should pick up oxygen and come back into the left atrium through pulmonary veins. The left atrium will then send the blood to the left ventricles, out to the aorta. Now the change in color from blue to red means that you have oxygenated blood. So that oxygenated blood is going to go out to the organs and perfuse the organs in the systemic system. However, if the baby is experiencing persistent fetal circulation, Blood is going to flow in to the right atrium and right ventricle. However, most of that blood will be in the right atrium and shunt through the patent foraminal valley. So you will get some blood flow to the right ventricle. You will get some blood flow up to the pulmonary arteries. But if you look at what's happening in the pulmonary arteries, you still have a patent ductus arteriosus. So since that ductus arteriosus is patent, blood will flow into the pulmonary arteries and then shunt through that ductus arteriosus that is still patent and now mix in with the blood that's in the aorta prior to, without it going to the lungs. So the blood flow gets mixed in two places. It's going to get mixed because it's coming from the right atrium over to the left side of the heart, to the left atrium. So that ductus, foraminal valley will cause a right to left shunt. As we discussed earlier when we did our review of circulation, once the fetus is born and is now a neonate, the left side of the heart has higher pressures than the right. But as you see here, with persistent fetal circulation, the right side of the heart has a higher pressure than the left. That's why blood is able to shunt from right to left through this foraminal valley. If the pressures on the left were higher, it would be shunting from the left through the foraminal valley to the right. That is not the case, as you can see here with the color change. There's higher pressures on the right than there are on the left. So blood will shunt from right to left through the foraminal valley and then mix in with the oxygenated blood. So you got a lower saturation of oxygen coming into that left ventricle before it goes out to the aorta. Then once in the aorta, there's more deoxygenated blood that's lowering the oxygen saturation of the hemoglobin even more. So you have hypoxia obviously ensuing with these patients, with these neonates. Okay, this is what a patent ductus arteriosus looks like. Obviously, these are cadavers, and this heart was from a neonate who obviously didn't make it, but or it could have not necessarily been a human, but it could come from another mammal that has similar structures that we do. But the ductus arteriosus is patent or dilated here, as you can see, the wideness from one side to the other. They just took a rope here and trying to show you the walls of that ductus arteriosus. And when they do PDA ligations, so they ligate the PDA, basically they just go in and they tie a string around it. And it causes it to close off, constrict, and turn into a ligament. This is what it looks like. This is an older heart, older child, not a neonate. But you can see here, once that ductus arteriosus constricts and turns into a ligament, the walls are pretty close together and it's no longer hollow. It is the walls, when it constricts, the walls come together and closes that area off. And like I stated earlier, it becomes a ligament. So this is what's normal. It's what a normal heart would look like. Because it still would show that there was some type of connection, but now it's a ligament and it's not hollow, so no blood is flowing through there. Versus a patent ductus arteriosus looks like that. All right, so now that you are aware of the issues that should be on your mind, that can occur prior to the baby being delivered, whether it be ventilation issues or circulatory issues. Now you have to prepare to resuscitate. So a lot of that is just the mental part of it. What is it that I could expect? What is it that I may see and may not see? So the anticipation of it. And in order to anticipate what's going to happen as best as you can, because sometimes you can anticipate it and you've done all the preparation mentally due to asking the correct questions, which we'll talk about in a moment. You could do all that and the baby could come out and everything could be totally different. So on the good side, so baby could come out and not need much intervention, or the baby could come out and be totally opposite of what you were thinking, to the point of death. Being a baby could just be delivered and already be gone. And there's nothing really to assess or to do other than give the baby to the parents and let them deal with that reality. So anticipation, that's a very, very big part of this whole process. So you want to know the following: maternal and fetal history as much as possible, know mom's vitals, know what's going on with fetal heart rate. And this is during the labor and delivery phase of it, which we're not typically a part of, but when they call us to come to the delivery, these are things that you want to definitely be aware of. So you might have to ask those questions. If nothing else, you want to know the history of the pregnancy. What gestational age is the neonate or fetus at this point? What gestational age is the fetus? And is the meconium, is there any meconium present, or is the amniotic fluid clear? Those are the two main questions that you need to ask when you are requested to attend a delivery. Then you want to know about how the mom and the fetus are doing during the labor and delivery phase. How is the baby responding to the contractions and so forth? Is mom on any intervention? Sometimes moms have to be placed on oxygen. Their heart rate and blood pressures may be affected due to the stress that's being placed on their bodies trying to get rid of this fetus. So all those things are good, good information to have so that you know what you're walking into. Properly functioning equipment and supplies are very important. At the very beginning of the shift, always make sure that you go to the labor and delivery suites. Do not depend on the previous therapist to have stocked everything for you. Depending on the kind of shift that they had, they might not have been able to get to everything. Also, they may not be aware that someone came into those rooms and got some of their equipment. So it is up to you at the very beginning of the day to check your rooms. That way you can validate, yes, I know exactly what I have in here, what supplies are available to me at a moment's reach, and you won't be surprised during a delivery when you can't find stuff. Properly functioning equipment also deals with making sure you have a variety of sizes. You may think that the baby is preemie, and by the time they get the baby out and hand them to you, you're like, man, this baby's been here for a minute. So if you were preparing with just preemie sized equipment and then the baby comes out bigger than you expected, now you're scrambling to get the appropriate sized material. So have varied sizes because you just never know. And then make sure you have trained personnel. So if you're going to have multiples, you need more than one therapist. You cannot attend to both or multiple numbers of babies if it's just you, because one baby may come out and then the other one could be right behind that one, and you can't split yourself in half. So you need trained personnel. So it's always good to know what you're dealing with ahead of time so that you can have the appropriate staff there to handle the situation. Okay, neonatal resuscitation supplies and equipment. At the very least, you need suction. You need something to deliver ventilation with, so bag mask ventilation via flow inflating or self-inflating bag, or a T-piece resuscitator if your facility has one. Intubation equipment, you need your laryngoscope, the blade, the ET tubes in order to intubate the neonate. We do not use stylets clinically, but you may see some therapists that prefer them and swear by them. But the tubes that we use are rigid tubes, so there's really no need. They go right in very easily without having to use a stylet. But there are some therapists that swear by them and say they need a stylet in order to put in the ET tube. The purpose of the stylet is to give the tube a little more rigidity, but they're already rigid tubes, so it's kind of pointless to me. And then medications. Obviously, epi is one of the major drugs of choice, so make sure that you have epi on hand. And if you are in a labor and delivery suite, or also in the L&D suites, the crash cart obviously is going to be where the meds are going to be located, and they should be in the room during the procedure anyway. So your meds will be there, everything that you need. And then miscellaneous items like meconium aspirator. That's a miscellaneous item that you may need. NG tube. You might need an NG tube if you're going to have a if you're going to be delivering positive pressure ventilations for a prolonged period of time. You want to make sure that an NG tube is placed. Okay, once you are in the room and they are ready to start with the delivery of the baby, you are it in a lot of hospitals. Larger hospitals, there will be a nurse, a neonatal nurse, and a therapist to attend to the neonate. In small hospitals, you are everything for the baby. So there'll be a nurse for the mom, and you will be the person for the baby. So they push that baby out, they're handing you the baby. You are doing these steps right here to determine if any intervention is necessary. So warming the baby is first and foremost. When that baby is delivered and the doctor turns around to hand the baby to somebody, and that somebody may be you need to be right there by that doctor's side with a receiving blanket to grab the baby, okay? You then will bring the baby over to the radiant warmer. And the radiant warmer it's not an incubator, it's open on the left and right side. There is a heater above the baby. So just like the light that you put food under at a restaurant or something. But the baby will be under a radiant light, and usually the mattress is a warming mattress as well. So the top and the bottom of the baby is going to be receiving heat. We don't typically wrap them up or keep them covered up, but we do vigorously warm them because we're trying to get all of the liquids that were on them due to the delivery off, because all of those things could contribute to heat loss. So thermal regulation will prevent the neonate from having heat loss, and there are 4 methods by which the baby can lose heat. So you need to know what they are, and then as this PowerPoint states, you need to know how to minimize it. So radiant heat loss is a big one, and we can minimize radiant heat loss by placing the neonate in a radiant warmer, which is what we do when they hand the baby to us. And then, get that out the way. Conductive heat loss is minimized by placing the neonate on a warm, dry blanket, towel, or heated mattress, or heated mattress. So you want to make sure that, again, when they give you the baby, you have a receiving blanket. You're going to use that as you're walking over back to the radiant warmer. You're using that to dry and stimulate the baby. Once you get to the bed, you're going to remove that blanket immediately. Lay the baby on the new blanket. So there should be a receiving blanket laid on the radiant warmer, ready and waiting for you to come back. You're going to take the one that you received the baby with. So that's two, one on the warmer, one that you have in your hand. You receive the baby, warming, drying, stimulating, come back to the bed, get rid of that blanket, lay the baby down on the new blanket. Now, once you lay the baby down, and I usually have 2 layers. Once you lay the baby down on that top layer, I'm using that top layer to get rid of any excess that maybe I was not able to address with the first pass. Then I'm getting rid of that one. Now you're laying the baby on, at that point you should have everything off. If not, it's best to have towels available so that you can utilize a towel to get, sometimes it's so thick, there might be a specific area that you might have to focus on a little more than others. But the conductive heat loss is minimized when you do that, when you make sure that there's nothing touching their skin that is a method for which you can get rid of heat. So make sure that they are on dry surfaces, warm, dry blanket, warm, dry towel, or a heated mattress. And then evaporative heat loss minimizes using, it is minimized by using warm towel to dry the neonate. If you have liquid on their skin, it is a source for heat to be evaporated from the top layer of their skin out of their body. And then convective heat loss is minimized by a warm room and not moving the baby a lot. So convective heat loss. Now, once you have received the baby, you've warmed the baby, now you need to position the baby. You don't want to lay the baby on their tummy. The most appropriate position is on their back. Also, you can lie them on their side, but they need to be slightly Trendelenburg. So their feet should be slightly higher than their head. And most radiant warmers already are positioned to where they're automatically going to be in a slight Trendelenburg, and there's nothing you physically have to do. Others, you may have to use a wedge or a rolled up towel just to get the end of the bed to be a little higher. Once you position the baby in the radiant warmer, you want to open the airway and suction. The neck should be extended and shoulders elevated. The best way to do that is to just take a washcloth. And all that stuff will be really readily available, especially if you're in the OR environment for C-sections. But you just take that rag, roll it up, put it under their shoulders, and it gives them that slight elevatedness, which will cause the head to drop back slightly. So you don't want to hyperextend where their head is way back like that, and you don't want their chin and their chest. So you just want that slight lift of the shoulders, which will allow their head to fall back just perfectly, so that you can be sure to have their airway open properly. This is very important in anatomical malformations. So if the anatomy is not formed properly where the airway is concerned, if you have that position to where their shoulders are elevated, it will help alleviate some of those anatomical malformations that are preventing air from moving into the lungs. So once you have the airway open and you have them positioned properly, suction the mouth, then the nose. You never, I don't care whether it's an adult or a neonate or a pediatric patient, you never want to go in their nose and in their mouth, putting their boogies in their mouth. That's nasty. So always suction the mouth, then the nose. You're going to, if the baby is stable, you're doing that with the bulb suction. And when you are doing so, you want to make sure that you are gentle and limited, especially if you are using a suction catheter, because obviously, as you know, suctioning can cause vagal stimulation. And vagal stimulation causes the heart to slow down, and it could also stop. So it may induce a severe bradycardia, which could lead to apnea. No, not apnea. That's the lungs, which will eventually lead to apnea, but which can lead to the heart rate totally stopping and the heart no longer functioning, which would then lead to the lungs no longer functioning. But yeah, severe bradycardia to where the baby's heart rate could stop altogether. Now, once you've done all of that, you've warmed the baby, you stimulated the baby, you position the baby, you got the airway open, you suction them out. Now you need to evaluate some other things that will also help you establish what we call an APGAR score. So we're looking at the respiratory effort, not just the rate, but the effort. We're looking at the heart rate, and we're looking at the color. Once we know those things, we will be able to give the baby a score, and that score will determine whether they're going to go lay on mommy's chest and have some tummy time, or whether they are heading to the intermediate nursery or NICU. Okay, meconium is something else that you need to be mindful of, because if meconium is present, typically what it means is that this baby has baked a little too long. In other words, post-term babies, so babies past 40 weeks typically have meconium. So that's why it's good to ask what gestational age is the baby. And if they say, oh, 42 weeks, then you want to know, is the meconium clear? Is the amniotic fluid clear? If it is not clear, then your thoughts regarding this being a post-term baby and possibly having meconium would be true. So if meconium is present, you need to know how to adequately prepare and respond to this patient. So upon delivery of the head, they are going to suction the mouth, suction the oral pharynx and the larynx with the suction catheter. And this is to remove any presence of meconium before the baby comes out and has the ability to be super active and respond to our environment, and possibly get some meconium in their lungs. The goal, once we deliver a baby that had meconium present in the amniotic sac, the goal is to not vigorously stimulate them. The goal is to bring the baby out. Hopefully, if we don't stimulate them, they won't start to cry and wail around and Okay, once they do that, once they take that deep breath, all the meconium that was present on the vocal cords or above the vocal cords are now possibly in their lungs. So we don't want that. So if the neonate is distressed once they're delivered, go ahead and intubate the trachea immediately, attach a meconium aspirator, and then suction as you are withdrawing that ET tube while applying the suction. Now, once you've done that, if the ET tube is clear, or the meconium aspirator with the ET tube on the end is clear, then you're done. You do not have to re-intubate them and do the suction. However, if it's not clear, you're going to get a new one, discard that ET tube, get a new one, and do the procedure again. And you're going to continue that until once you come out of their lungs, the end of the ET tube doesn't have any meconium on it and it is clear, then you can stop. So when you're applying suction, suction should be set at 100 millimeters of mercury and applied no more than 3 to 5 seconds. This is repeated with new tubes each time, as I stated earlier, in an attempt to remove most or all of the meconium. Blow by O2 can be delivered to help alleviate hypoxia. So of course we're going to use the chart with the appropriate saturation for the given times. I think at the 1 minute mark, it can be 60, a sat of 60, and we're cool with that. So that baby would not need any supplemental oxygen. So you need to make sure you are mindful of that saturation chart and you use that as your indicator on whether the baby needs any oxygen. Otherwise, you're going to give them 21%, just in case they need the flow. All right, so when you're evaluating respiratory effort, if gasping respirations or apnea is present, then you want to provide tactile stimulation by vigorously rubbing them, cleaning them, drying them off. If respirations do not improve, we're going to begin positive pressure ventilation. So what that does is it tells us, that first bullet is telling us that this baby is in secondary apnea. We tried to stimulate them with tactile stimulation, and the baby did not attempt to ventilate, didn't attempt to ventilate at all. If that occurs, now the intervention that needs to take place is positive pressure ventilation. And we're going to either do that with a bag mask, with a flow inflating bag, or bag mask with a self-inflating bag, or a T-piece resuscitator. So flow inflating, self-inflating, or T-piece resuscitator are what we're going to use to give the positive pressure ventilation. We would then assess them in 30 seconds. And the assessment tool that we're going to use is check the pulse. So if we started positive pressure ventilation and we started it because their respirations were poor or absent, the way that we determine if we need to continue the positive pressure ventilation is not looking at their respiratory effort again. The indicator at this point is to check the heart rate. If the heart rate is above 100, then you do, I don't like the way that's worded. It says if not, initiate. Well, that's true. Okay, I thought it said something different. Okay, so if you evaluate the heart rate and it is not above 100, then you need to do positive pressure ventilation. So we did 30 seconds of positive pressure ventilation because they were not breathing. Now we're going to check the heart rate. The heart rate is below 100. So we're going to start positive pressure ventilation, or continue, because we were already doing it for another indication, but continue positive pressure ventilation for another 30 seconds. After we've done that for a full minute now, if they're still not breathing and their heart rate is now below 60, that means that we need to begin chest compressions. And I know it's not stated here, but it will be in a later PowerPoint. So the first 30-second interval, we're checking heart rate. We're doing that on the umbilical stump. What we do is we feel for pulsations for 6 seconds. If we did not count to at least 10 within that 6-second mark, we know that there's 10 times, what am I trying to say? 10 times 6 seconds is 60 seconds, yes. So if we had 10 beats within that 6 seconds, we multiply that by 10, that's 100. So the heart rate would be at least 100. If we counted and we didn't count at least 10 within that 6 seconds, we know their heart rate is less than 100, right? So we know at that point, we need to continue positive pressure ventilation for another 30 seconds. Now it's been a full minute. Now we need to know, is this heart rate less than 60? So if within that 6 seconds, we don't count at least the number 6, because 6 times 10 is 60, then we know we need to start chest compressions, okay? They also state here that if the heart rate is 100, so at this point, we're trying to determine how well is this blood circulating? How well is the heart circulating blood? We know the rate is good, but now we need to look at color to determine, are they able to perfuse the body with this rate? So we evaluate color, and we will talk about color here now. So the colors that we're concerned about are pink and blue. We want the baby to be pink. However, some pink babies can have signs that the baby is not transitioning well. So if the core is pink, that's your abdomen, your chest cavity, abdominal cavity, neck, and head are all pink or normal skin color for that baby. But the arms and legs are blue, we call that acrocyanosis. Acrocyanosis is when you have a pink core with blue extremities. Those babies just need to be monitored. They don't necessarily need to go to intermediate care or to NICU. Acrocyanosis is normal, but we do need to monitor them. We do need to check on that baby a little more often than we would with a normal admit. Blue babies, however, meaning they are blue from head to toe, need some supplemental oxygen, obviously, if their saturation is low. Here's the thing. You can have blue babies, but because of the anatomical malformations on the inside, they may be able to keep their sats up. It's pretty interesting, but we'll talk about that when we get to neonatal cardiovascular, cardiogenic issues that may occur with neonates at birth that could cause that to happen. So if the baby is blue, they may need to get some supplemental O2 in order to keep them from going into distress before heading to surgery to fix the anatomical problems. All right, positive pressure ventilation. This is going to go a little deeper into when to do it, when is it indicated, how do you do it, and so on and so forth. So indications. Most typically it's because of respiratory effort, whether the baby is apneic or gasping, that is showing poor effort, obviously. Or when spontaneous breathing cannot maintain a heart rate greater than 60. Because if the baby is breathing spontaneously, the heart should be beating, that should be greater than 100, I'm sorry, greater than 100, not greater than 60. So apneic, gasping, or when spontaneous breathing cannot maintain a heart rate greater than 100. Ventilation must always be done with 21%, regardless of the device you're using. So a self-inflating, flow-inflating, or a T-piece resuscitator, we're always going to start at 21% on the blender. Then we will wean the FiO2 up where necessary in correlation with the baby's SAT. Oh, the pulse ox, that's another one of those miscellaneous items you need. Every delivery, neonatal resuscitation program requires that every delivery has, every baby that's delivered has a pulse ox placed on their little foot. So you just wrap the band around their foot, around the palm of their foot, I guess, and that's done like pretty early on while you're drying and stimulating. You need to be applying that pulse ox because that's going to determine whether you need to give the baby oxygen. So a tight mask seal is required because you're going to be delivering positive pressure ventilation with a bag and a mask, or with a device and a mask. And pressure should not exceed 40 centimeters of water pressure. So depending on whether it's a term or preterm baby will determine what pressures you need. We're going to be looking at chest rise, but remember, preemies need higher pressures. I know it sounds odd because they're so little, but they need higher pressures because their lungs are going to be stiff because they most likely will not be producing that type 2, the surfactant through the type 2 cells because they're delivered so early. So they will have problems with stiff lungs. So those are the ones that we will ventilate in the 30 to 40 range, versus the term babies will be more in the 20 to 30 range, pressure wise. The respiratory rate should be anywhere between 40 and 60 breaths per minute. You're going to continue positive pressure ventilation for 30 seconds, and then you're going to reevaluate the heart rate. As I stated earlier, if you determine that the heart rate is greater than 100, and they're breathing spontaneously, then you don't have to do any more positive pressure ventilation. What you did worked. That's the goal. If they're not ventilating properly and they don't have a heart rate greater than 100 on your initial assessment, positive pressure ventilation is the therapy that is needed. And that therapy should turn that baby around. It's amazing how miraculous that happens. It's like baby comes out, the baby looks like crap. We do a little positive pressure ventilation, 30 seconds, maybe a minute. Baby is perfect at that point. Never needs any more intervention after that. It's just coming into our environment is a big shock on their bodies. And sometimes it just takes them a minute to get it together. Okay, now if you're doing positive pressure ventilation for 30 seconds and you reevaluate the heart rate, and that heart rate is still less than 60, now you're going to do positive pressure ventilation and chest compressions. Finally, we're doing chest compressions. If we do the chest compressions and the positive pressure ventilation and the heart rate is persistently bradycardic, less than 60, now we need to give some meds. We need to give the baby some epi. We also need to consider, as it states here, to insert an NG tube if we're going to be delivering positive pressure ventilation for more than 2 minutes. As you know, there's 2 tubes, trachea in front, esophagus in the back. If you are bagging anybody, I don't care the age, you have the likelihood of getting air in their tummy. So that is why they say insert the NG tube, because we don't want their intestines now pushing up on their lungs, causing more difficulty to expand them, creating more atelectasis. Now with chest compressions, you have 2 methods that you can utilize. You can do the 2 fingers in the center of the chest, or you can do the thumbs encircling hands technique, where you use your fingers as a basically a backboard, and then your fingers wrap around their chest and you do the compressions in the center. For some reason, men seem to like the thumb encircling hands technique because it allows them to not be so aggressive when they're doing compressions versus the two fingers. It's like you could use more pressure there and not really realize it. So to each his own. But I will tell you, if you are the only one attending to the neonate, you can't do both. You can't do, thumbs encircling hand technique and ventilate the baby at the same time. Because the thumb encircling hands method is best done from the side of the bed, so either the left or the right. And if you're bagging the baby, you're bagging them from the head of the bed. So you don't want to move to the side, do the compressions, move to the head, do the bagging. That's not the most ideal way to do that. So what is ideal is to bag the baby and then compress the chest, and then bag the baby again, and then compress the chest by doing the center of the chest method. Okay, the indications for chest compressions, we've already talked about it. After you reevaluate the heart rate after 30 seconds of positive pressure, and the heart rate is still less than 60, now it is time for chest compressions. And if the heart rate is persistently bradycardic, then you will continue said chest compressions. You discontinue chest compressions if the heart rate increases above 60. Not above 100, above 60, then we stop. We don't start it till it's below 60, and we don't stop it until it is above 60. Okay, as far as intubating babies, obviously we're going to intubate if there's meconium present, but outside of that, we consider intubating babies if we're trying to bag them and it's difficult to bag them, or our attempts to resuscitate are ineffective. Prolonged positive pressure is required due to some type of lung condition where we know we're going to have to put them on a ventilator. We will DC this attempt if bradycardia or desaturations occur. So if we're attempting to intubate and the baby starts to experience bradycardia, their heart rate is starting to drop, or their saturations start to drop, they're desatting, then we would stop the attempt at that moment, let the baby recover, and then attempt our intubation again. The blade sizes is really 3 of them. You got a size 1 blade, a size 0 blade, and then a double O. We got the double O blades for the extremely preterm. So that's a really short, skinny little blade. We use Miller blades, not Max, for neonates. Now for the ET tubes, the easiest way to remember this is always think 3.5. Most typically, we're not attending deliveries of term babies, just not typical. Most typically, we are attending deliveries for preterm, 34 to 38 weeks, still considered preterm. 38 to 40 weeks is considered term. Post-term is bigger than 40 weeks or longer than 40 weeks. And then under 34 weeks is considered extremely preterm. So always think 3.5, go up if they are term, go down if they are preterm. And if they're extremely preterm, then it's a whole size smaller than the preemie. So 3.5 is the starting place for 34 to 38 weeks. They weigh about 2,000 to 3,000 grams, and the outcome is typically good. If the baby is 28 to 34 weeks, their outcome is typically fair. They weigh 1,000 to 2,000 grams, and we're going to use a size 3/0 inner diameter ET tube. Extreme preemies are we're going to use a size 2.5. They weigh less than 1,000 grams, and these babies are less than 28 weeks. Their prognosis is poor. And most typically, we're not intubating these babies. If they're less than 28 weeks, I mean, there have been some 26-weekers that get interventions and make it. It really depends on your neonatologist. If you have a neonatologist who's very progressive, then yeah, you might be intubating these babies that look like their skin looks like burgundy. Maybe not burgundy, like it's a purplish fuchsia, deep burgundy fuchsia looking color. I don't know. But their skin is like see-through. You can see their blood vessels. It's really crazy. And usually though, the doctors are telling the parents ahead of time, look, there's not much we can do. But if the parents say do everything, unless that neonatologist wants to take on the legal ramifications of not doing everything after they said to do everything, then you have to, we as healthcare professionals typically err on the side of doing whatever the parents request. The sad thing is sometimes we know we're doing it to the detriment of the patient and kind of spinning our wheels, because no matter what we do, we probably won't get them back, especially when you're dealing with a baby that's in secondary apnea and we have no idea how long they've been that way. The likelihood of us getting them back is slim to none. Okay, so those are the ET tube sizes. Always start with 3.5, go up a half if they're term, go down a half if they're extremely preterm. But if they are extremely preterm, then you're going to go down one whole size. So instead of 3.5, 2.5. All right, the meds. We already talked about epi. Epi is used for persistent heart rate, persistent bradycardia, heart rate less than 60. Volume expanders are important if you're dealing with a patient that has had hypovolemia. So if we know that they have been bleeding out or have been losing volume, then we need to volume expand them once they get here. Sodium bicarb is another drug that we may need to consider if we've been coding this baby for a while and they don't seem to respond to any other therapy. They may need some sodium bicarb. Of course, dopamine is a drug of choice for when there is continued depression of the cardiac system. So we can give dopamine to help increase those pressures in hopes to make that heart work faster. And then Narcan and then naloxone. Narcan, which is naloxone, is used if we know that mom was given or had taken a narcotic within the past 4 hours. That means that baby too has received that narcotic, and now we need to reverse the effects of that narcotic. So we need Narcan. Okay, APGAR scoring, really simple. With APGAR scoring, either it's great and they get a 2, or it doesn't exist and they get a 0, or it's somewhere in the middle and they get a 1. So if their heart rate is 100 or greater, they get a 2. If their respiratory effort is great, they're breathing just fine, no problems with color or anything like that, chest rise is great, all of that, they get a 2. Muscle tone, if they seem to be keeping their muscles tense and moving around and all of that, then they get a 2. If they don't have any muscle tone, it just seems like they're just flaccid in the bed, then they get a 0. If they're somewhere in the middle, not very active, but if you bother them, they'll, kind of respond, that kind of thing, then then they're a 1. Now, reflex, we look at the moral reflex. We look to see if we touch their corner of their lip, do they turn their head towards you, that kind of stuff. We look to see if we lift their arms, and once we let their arms go, do they give the impression that they feel like they're falling? If they respond appropriately, then that's a 2. If they don't respond and everything flaps back down, then that's a 0. If they don't turn their head when you do the sucking thing, then that's a 0. However, if they're somewhere in the middle, like they kind of, maybe they didn't totally do the response when you let their arms go right away, but maybe right before it got to the bed, you saw them flinch a little, then they would get a 1. Same thing with reflex. If you stimulate them and then they, just kind of, just a little, like they're bothered a little, but not like some babies are like, ah. If they have a slight reflex, then that would be a 1. So it's really simple. Don't make it hard, because as a therapist, you may be the only one that is responding to the baby, and therefore the person that is doing the recording may ask for the APGAR. At that 1 minute, 5 minute, 10-minute mark, they may ask for someone to yell out the APGAR score, and you may be it. It may be totally up to you, and it's subjective. It really is. So somebody may be like, it's not a 9, it's a 10. But at some facilities, they will not give any baby within that 1 minute mark a 10, no matter how good they look. It's like those preceptors that are like, none of my students get a 4. Nobody's a 4, whatever. So it really depends on the culture of your facility on whether they will give a perfect baby a 10. They may give a perfect baby a 9, saying that, well, everybody has some room to do better. Who knows? So find out what the culture is, and I guess either go with it or buck the system and try to make them change the culture. Okay, so as it states in that second to last bullet, each category is given a score from 0 to 2, 2 being the best, obviously 0 being the worst, and then 1 being somewhere in between. You get the score at 1 minute, 5 minute, and every 5 minutes up to 20 minutes if the baby is depressed. So usually if the baby is depressed, the baby's going to be in the room a whole lot longer because we're going to be intervening and doing therapy. If the baby is not depressed, usually within that 5 to 10 minute mark, we have done all the assessing that we need. We've given the APGAR scores, and now we're ready to give the baby to mom and let them do some bonding, right? So APGAR score is very important, and you need to know how to assess it. Here's a chart that goes over the stuff that we just talked about. Same thing. And then this talks about how to respond to certain categories of score. So if the score is between 7 and 10, we consider that baby to not be depressed. We're going to suction the mouth and the mouth, then the nose, assure that their airway is patent, monitor their vital signs, maintain their body temp. And then, of course, we can give the baby to mom. Moderate depression, a score between 4 to 6. You're going to start treatment immediately. By the way, these ranges can be different depending on your clinical site. So at your clinical site, maybe the non-depressed stage is 8 to 10, and the moderate depression stage is 7 to 5 or something like that. So it really depends on your facility. These ranges that I'm giving you are for the NBRC hospital. So for test purposes, these are the ones you need to remember. Okay, so moderate depression score between 4 and 6, start treatment immediately, suction the mouth and the nose, assure that the airway is patent. You want to stimulate, because stimulation could be the reason why their score is between 4 to 6. And the more you stimulate, the more likely their scores will start to come up. Continue to monitor their heart rate. If the heart rate is less than 60, then you want to bag them. That should say 100 again. Golly. If the heart rate is less than 100, you want to bag them. You know, if it's less than 60, then you want to bag mask and compressions, chest compressions. And you're going to use a SAT to determine if they need oxygen. So we're bagging with 21% unless the saturation tells us otherwise. And then we're going to be observing these babies for 24 hours. Now, if the APGAR score was between 0 and 3, this baby is in severe depression. And we are going to obviously still suction their mouth and their nose, make sure their airway is patent, monitor their heart rate. We may need to suction via the ET tube. Maybe this particular baby could have had meconium, and that's why they came out in severe depression, because their airway was blocked with poop. We're going to do positive pressure ventilation with bag mask. And if their heart rate is less than 60 when we reassess, we're going to do the positive pressure ventilation with chest compressions. And then we're going to observe them for 24 hours if we're able to stabilize them. All right. In addition to the things we've talked about, we also need to be mindful of neonates' sugar levels, because as you know, in order to be active, we need to get that activity by burning off ATP, which happens by our sugar stores. So sources of fetal and neonatal glucose are listed here. The glucose uptake from maternal blood glucose levels is what typically happens when they're in the womb. You get the glucose from your mama. But as the baby develops, they start to store their sugars as brown fat. So fetal adipose tissue triglycerides, which we call brown fat stores, are used during stress. So preemies are at a disadvantage because they don't have the adipose tissue stores like term babies do. So they normally don't have to worry about, a preemie doesn't have to worry about utilizing their own brown fat stores, because they're getting sugar from mom. They're getting the glucose that they need from mom, so when they are in stress, they have something to burn. But when those preemies are no longer in utero and they're out in our environment and they don't have the brown fat stores to use during stress, they are at a total disadvantage. So sources of neonatal glucose, alternative sources are ketones, glycerol, and lactate. This is what the body will resort to if it does not get the glucose it needs from these brown fat stores. So your serum glucose levels will vary during the first 72 hours of birth, but level out at about 70 milligrams per deciliter. Abnormal glucose levels may be due to hypothermia, hypovolemia, or acid-base imbalances. So things to consider if the baby's D-stick is low. These are the things that could cause it. So how do we manage a baby's serum glucose? We first need to be able to test them. So we need to test them for hypoglycemia, and they are considered hypoglycemic if their levels are less than 45 milligrams per deciliter. You can look in your text. It has a box for the clinical signs of hypoglycemia and the causes of hypoglycemia. But the one that is most seen on the MBRC exam is hyperinsulinism. So if your baby has too much insulin and it's not breaking it down properly, then the baby can be hypoglycemic. D-stick, I mentioned that earlier. That's how we're going to measure it. Stick the baby's heel and collect the specimen and run it. High risk factors for babies to have hypoglycemia are infants of diabetic moms. So if mom had maternal diabetes, then the baby is at risk for hypoglycemic, being hypoglycemic. If there was RH incompatibility with mom and baby, so if mom is RH positive and baby's RH negative, then they're incompatible. And that could also put them at risk of hypoglycemia. If the baby is SGA, which means small for gestational age, it puts them at risk, and also preemies. And being born premature is different than being SGA. You can be a preemie and be SGA, or you could be a preemie and be LGA, large for gestational age. But the large versus the small just means we expect a baby born at this particular gestational age to be about this size. And if you are smaller than that, then you're SGA. If you are bigger than that, then you're LGA. Being premature has to do with the exact gestational age that you were born. And if you were born between the window of, well, less than 38 weeks, let's just put it like that. If you were born sooner, earlier than 38 weeks, you are considered a preemie. But you could be normal sized and go home, just like a term baby. It's just a category, a label of sorts. But sometimes that label is important because it does reveal itself to show that things haven't developed like they should, like they typically would have at this gestational age. So we have to respond with therapy. Okay, treatment of hypoglycemia. We're going to feed the baby, and hopefully that'll bring it up. And if not, we're going to give them some D10W, not the oil, not the D. Was that D5W? I can't remember. Dang, I was trying to make a joke, and that just really flopped. But anywho, D10W is what we're going to give them to bring up their sugar levels. Last slide. Woohoo! If we need to be able to access get access for blood samples. So whether we're trying to give medication or draw blood from the baby, the umbilical stump is the best route to go for that. And we can do arterial sampling as well as giving medications through that. Now, when we place an umbilical artery catheter, as we talked about in the chapters 1 through 3 lecture, we're going to do it with we're going to insert it into the umbilical vein. The umbilical vein is the larger of the 3 vessels. Once you cut the umbilical stump, you'll see one big hole and 2 little holes. The 2 little holes are the umbilical arteries that are coming from baby to the placenta. The umbilical vein is coming from placenta to baby. So if we're trying to get blood right into the circulation and that's going to go to the heart and right out to the baby, then we want to do it through the umbilical vein. And the best place for us to see what is going on in arterial circulation is to put it through the umbilical vein, because that's where blood that left ventricle and went out to the rest of the body is going to end up there for us to evaluate it. So if the baby is term or close to term, really about 30 weeks or so, they're going to weigh about 1,250 grams. Those babies need a 5 French catheter inserted. If they are less than 1,250 grams, so if you remember this, a 28 weeker is about 1,000 grams. So if they are less than that, well, if they are about that gestational age, then they're close to that 1,250. You're going to use a 3 French for those babies. Once you have inserted that catheter, you want to obtain a chest x-ray to make sure it is in place correctly. Okay? Well, that's that. Thank you for for listening to my lecture, and I hope you enjoyed. Bye-bye.